Hi everyone, in this short video, we will be discussing gastric ultrasound on patients who chewed gum during their preoperative fasting period. The main intention behind this educational content is to teach how to correctly use and implement point-of-care ultrasound as part of your anesthetic practice. Point-of-care ultrasound is a very valuable tool in a clinical setting. Although aspiration of gastric content is sometimes rare, we feel that we can further minimize its incidence with the use of preoperative gastric ultrasound. In this video, we are going to discuss the importance of using gastric ultrasound. We will focus specifically on patients that have chewed gum before their surgical procedure. As we know, NPO guidelines are used for the purpose of protecting the individual. Aspiration in the perioperative setting is known to significantly increase morbidity and mortality. The sedation medication we provide during anesthesia block the sphincter tone in the lower esophagus, decrease the reflexes in the upper airway, leading to an increased risk of aspiration. Knowing this, it is clear that gastric content and volume is the most important modifier in preventing pulmonary aspiration during anesthesia. The American Society of Anesthesiologists recommends patients to fast from fatty food or meat 8 hours prior to surgery, non-human milk or light meals for 6 hours prior, breast milk for 4 hours prior, and clear liquids including water, pulp-free juice, and tea or coffee without milk for 2 hours prior to the anesthetic. These guidelines may be unreliable because comorbidities are not taken into consideration. Examples of these include emergent procedures with uncertainty of last known mealtime, altered mental status or cognitive dysfunction, language barriers, pediatrics, inconsistent history, and any comorbidity that may cause delayed gastric emptying like pregnancy, diabetes, neuromuscular disorders, severe obesity, severe liver or kidney dysfunction, or critical illnesses. As described by the Nagelhout nurse anesthesia text, Mendelssohn syndrome, also known as aspiration pneumonitis, can occur when gastric content with a volume greater than 25 milliliters and a pH less than 2.5 enters the lungs. When this occurs, lung tissue injury may result, leading to severe respiratory damage. So why do people without comorbidities that cause delayed gastric emptying still have residual gastric volumes even while fasting? This is because there is a basal amount of gastric acid secretion that occurs independently of eating or drinking. Basal secretion of gastric acid is normally higher at night and less during the day. So, the day of surgery, if a patient has not eaten since midnight, it is expected that they still have minimal amounts of gastric volume that is considered normal. Therefore, it is important to utilize gastric ultrasound when necessary to get an accurate measurement for risk stratification when making your decision on whether to proceed with surgery or not. NPO guidelines are centered around healthy patients undergoing elective surgeries, as mentioned earlier, excluding situations like emergencies, pregnancies, and any other major comorbidity that would alter their status. There is question regarding the status of patients who chew gum, dip tobacco, eat candy, mints, or cough drops in the preoperative area. This video will specifically be focused on the use of gum preoperatively. There remains controversy over if the cephalic phase of digestion, for example by chewing gum, increases secretions and swallowing to the point of exceeding NPO limits, or if it promotes gastric emptying. There are several scholarly studies that have attempted to set concrete evidence regarding the risk of chewing gum in the preoperative period, but there is still a lack of consensus regarding this issue. Many studies have shown that there could possibly be increased gastric content leading to an increased risk of pulmonary aspiration, while other studies have led to believe that there is no risk with chewing gum preoperatively. The lack of definitive guidelines is the main driving force behind the purpose of this educational content. As we have already mentioned, ultrasound is a significant tool to utilize in the preoperative area, and the data we discuss in this video supports the rationale for its use. For adults and children that weigh greater than 30 kilograms, the curvilinear probe is used with abdominal ultrasound setting. For children less than 30 kilograms, the high-frequency linear probe can be used. For this study, a curvilinear probe was used as well as the all-in-one handheld butterfly IQ shown on the right side of the image. First, position the patient in the supine position. Hold the ultrasound probe in the dominant hand and use the indicator notch on the probe to orient yourself to the ultrasound screen. Apply ultrasound gel to the probe and scan over the patient's epigastric region with the probe indicator pointing cephalad. Use a rocking, rotating, tilting, and sweeping or sliding motion in the epigastric region with the probe in the sagittal plane until you get a similar picture to the one displayed here. It is often easiest to first locate the tail of the liver. In this picture, the liver is labeled L. The gastric antrum is labeled A. The pancreas is labeled P. The superior mesenteric artery is labeled SMA, and the aorta is labeled AO. As you can see, the gastric antrum should be visible in very close proximity to the tail of the liver. After the landmarks are visualized in the supine position, the patient is then placed in a right lateral decubitus position to allow gastric contents to be collected in the gastric antrum. Measurements must be taken from the right lateral decubitus for accurate NPO status assessments. After obtaining images, you then want to measure the gastric antrum. For the measurement of volume, you can use the calipers with the ellipse function, which are programmed into most ultrasound machines. If your ultrasound machine has a free tracing tool, you can also use this function to measure gastric volume. For the purpose of this video, we will be using the ellipse function to measure. To get an accurate measurement, you want to measure from the outside of the gastric muscle, serosa to serosa. The calculation for this measurement can be complex, but there is a great resource available on gastricultrasound.org. Once you have your measurement, you can use the measurement tool to evaluate if your patient is NPO. You need your patient's age and the ellipse measurement you obtained. Once you have this knowledge, you can make an informed decision on whether to proceed with the procedure. The patient is first scanned in the supine position. The patient is then placed in the right lateral decubitus position where more images are then obtained. The first subject used was a male, aged 33. He was 5'7". He weighed 185 pounds. He had no medical history, with a body surface area of 1.99 and a BMI of 29.0. The first image shown is completely NPO in a supine position. In this image, the subject is completely NPO but in a right lateral decubitus position. We then had the subject chew gum, and this image was obtained 15 minutes after chewing the gum. This image was obtained 30 minutes after chewing the gum. This image was obtained 45 minutes after chewing the gum. At the 1.5 hour mark, we then had the subject drink 100 milliliters of water to compare our results. Subject 2 was a female, aged 26. She was 5'4". She weighed 123 pounds. She had no medical history, with a body surface area of 1.59 and a BMI of 21.1. These first two clips show subject 2 completely NPO in a supine followed by right lateral decubitus position. Shown here is subject 2 15 minutes after chewing gum. We then see subject 2 30 minutes after chewing gum. This image shows subject 2 45 minutes after chewing gum. This image is from a butterfly IQ ultrasound. This also shows the patient 45 minutes after chewing gum. We then had subject 2 drink 100 milliliters of water so we could compare our results to. Lastly, subject 3 was a male. He was 28 years old, 6 foot tall, and weighed 220 pounds. He had no medical history, with a body surface area of 2.25 and a BMI of 29.8. These first two clips show subject 3 completely NPO in the supine followed by right lateral decubitus position. Provided here is subject 3 15 minutes after chewing gum. Next, the image was taken 30 minutes after chewing gum. An image was then obtained 45 minutes after chewing gum. And finally, subject 3 was also given 100 milliliters of water and measurements were obtained. Next, we will look at our overall findings and results from the study and determine who is considered NPO and who is at risk for aspiration. From the images obtained, sample 1 completely NPO had a gastric antrum less than 2 centimeters squared. At 15 minutes, sample 1 had a gastric antrum of 3.58 centimeters squared. At 30 minutes, the gastric antrum was 4.76 centimeters squared. At 45 minutes, the gastric antrum was 4.41 centimeters squared. And at 5 minutes post-water, the gastric antrum was 13 centimeters squared. Looking at sample 2, completely NPO, the gastric antrum was less than 2 centimeters squared. At 15 minutes post-gum, the gastric antrum was 6.08 centimeters squared. At 30 minutes post-gum, the gastric antrum was 4.75 centimeters squared. At 45 minutes post-gum, the gastric antrum was 4.52 centimeters squared. And 5 minutes post-water, the gastric antrum was 14.39 centimeters squared. Looking at sample 3, completely NPO, the gastric antrum was less than 2 centimeters squared. At 15 minutes post-gum, the gastric antrum was 4.30 centimeters squared. At 30 minutes post-gum, the gastric antrum was 10.23 centimeters squared. At 45 minutes post-gum, the gastric antrum was 9.24 centimeters squared. And at 5 minutes post-water, the gastric antrum was 9.17 centimeters squared. When comparing the chart displayed earlier with the results on this slide, sample 3 is considered not NPO. At 35 and 40 minutes post-chewing gum, sample 3 is noted to have a gastric volume that would place them at risk for pulmonary aspiration when undergoing anesthesia. Samples 1 and 2 were noted to remain NPO while chewing gum during their NPO period. These results displayed support the use and implementation of point-of-care ultrasound in a preoperative setting. As anesthesia providers, many times there will be negative feedback from surgeons, patients, and their family members, as well as hospital administrators regarding the cancellation of elective procedures due to the patient's NPO status, specifically those chewing gum. Tulane University Hospital conducted a study that showed that the cancellation of an elective outpatient procedure resulted in an estimated total loss of $4,500 per canceled operation. On the contrary, research shows that the cost of pulmonary aspiration leading to an ICU admission estimates to cost around $4,300 per day, with an average of a 7-day stay. So, when comparing both the cost of surgical cancellation per day versus an adverse event leading to pulmonary aspiration, wise judgment and precaution is warranted. With the use of gastric ultrasound, you have a valuable tool to defend your stance. So, what can anesthesia providers do if patients show up the morning of surgery chewing gum? A quote from Gala and colleagues says, "Whenever there are doubts concerning a risk assessment, ultrasound imaging of gastric emptying should be performed prior to taking any decision about the procedure, the method of anesthesia, or induction of anesthesia." By utilizing ultrasound on patients where NPO status may be questionable, the anesthesia provider has the ability to make a quick, rationale decision regarding proceeding or canceling a procedure. Overall, gastric ultrasound is a vital tool that anesthesia providers should use to evaluate gastric content and volume in the preoperative setting. We believe the implementation of gastric ultrasound in patients who chew gum the morning of surgery will ensure a safer delivery of anesthesia.